issues that may depart somewhat from the nature of the talks we've heard so far. I'm going to spend time talking about the immune system, lymphocytes, antibodies, aspects that we think are involved in the pathogenesis of these diseases that may ratchet up the complexity here. But I'm not going to apologize for it. I think these are important issues, and I think we can really best serve the TM community by educating each other. So I'm going to present some data about the immunopathogenesis of this disorder, and then open up the issue about what these things might teach us about the pathogenesis of transverse myelitis. So I'm going to refer to it here heretofore as ADEM. This disease falls under the general rubric of inflammatory demyelinating disorders of the central nervous system. The prototype disorder in this category is multiple sclerosis. Of course, the main reason why we're here is our interest in transverse myelitis, which you could characterize as a site-restricted disorder. So this is selective involvement of the spinal cord. There are, of course, other site-restricted disorders that involve the nervous system, including the optic nerves, and you've heard reference to optic neuritis, and indeed disorders that selectively involve the cerebellum. That's also to be kept in mind in contrast to another disorder, which I'm actually going to talk about a little bit, called experimental autoimmune encephalomyelitis, or EAE, which is a disease that's most typically induced in laboratory animals, which serves as a model for some of these diseases that occur in humans, and which you're also going to hear about from Dr. Ransohoff later on in this symposium. So in terms of the definition and clinical features of ADEM, these are, there is no one single strict definition of this disorder. They're often characterized in small collections of patients with this condition. They're typically characterized by a rapid onset of neurological symptoms. As the name implies, or at least the disseminated part of the name implies, there's involvement throughout the neuraxis, including both the brain and the spinal cord, resulting in typically multifocal neurologic signs and symptoms. Many patients, although not all, report a history of a preceding infection or immunization. You've heard a lot about that today, and actually that's one of the aspects of this that I'm going to focus in on and try to clarify for you to some degree. In general, these are monophasic illnesses. Of course, there are reports of patients with progressive or stuttering ADEM, but in general, this is a monophasic disorder. Pathologically, these diseases, when they do come to autopsy or biopsy, are characterized by inflammatory infiltrates in the nervous system tissue, often around blood vessels, and demyelination. So in terms of the diagnosis, it's often important to try to determine whether the patient will give you a history of an antecedent infectious illness or immunization. That in some series can be in a third to half of cases. The physical and the neurological examination are important. Indeed, there's a great emphasis placed on the MRI findings. Dr. Beauchamp made reference to that this morning, and the cerebrospinal fluid. Sometimes even with this collection of undertakings, it's not crystal clear that the patient has ADEM, and it's sometimes only after implementing some therapeutic strategy, particularly trying to manipulate the immune system in some way, or following the patients over time, both clinically and with MRI scans, does a diagnosis really become clear. So you might say to me, okay, and this is what the typical MRI features of ADEM might include. This patient has T2 hyperintensities in the brain, in the brainstem, and throughout the spinal cord. It's not unlike a lot of the MRI pictures you've seen already over the course of the day. And then you might say to me, well, how do you distinguish this disorder from multiple sclerosis? And we focus a lot of time and effort in that regard. I don't want to dwell on this too much other than to just make the case that patients with ADEM typically have rather more fulminant presentations. They get sick very quickly. They often have fever. They may have seizures. And even altered sensorium, whereas patients with multiple sclerosis may have a more relapsing, remitting, or stuttering pattern. But there are certainly cases of aggressive multiple sclerosis that can be very difficult to distinguish clinically and radiographically from ADEM. And again, I don't want to spend too much time on the clinical differentiation here because I want to get on to this issue that we've been talking about to a large degree over the course of the day about precipitating events. So I've made reference to the fact that many of these patients provide a history of an antecedent infectious illness or a para-infectious process, so that the neurologic syndrome occurs in the context of a recent infection. Also, many of these patients give a history of a preceding vaccination of some sort. And so I want to focus in a little bit on these issues to a greater degree and present some data, some of which has actually been out there for some time about the immunology of this. Again, with the question of what does this teach us, or how can this help us focus questions about the immunopathogenesis of transverse myelitis. So as an example, and Dr. Mandler made reference to it this morning, the classic post-vaccination demyelinating syndrome has been described in patients who've received the old Semple type rabies vaccine. So I'm going to spend some time talking about this. Again, there's a long list of other vaccines that have been implicated here. Hepatitis B vaccine has been on the hot seat recently, and the relationship between that vaccine and demyelinating events and multiple sclerosis has been the subject of a lot of investigation and controversy. In addition, there are a variety of infectious illnesses that have been linked to this. I'm not going to go through them in detail, but instead focus in on one, the encephalomyelitis that can follow measles infection, not because it's a particularly common problem here in the United States, but there has been a careful immunologic study of these patients, which I think may teach us some valuable lessons. Again, just to remind you that many of these patients with ADEM do not have a preceding vaccination or infectious history, but I'm going to focus in on two of these disorders. So I want to get and take you back, talk a little history here in terms of the neurologic complications associated with the old Semple rabies vaccine. And this goes back to the days of Louis Pasteur over 100 years ago. And one of the important contributions that Pasteur made was he was able to show that he could prevent rabies in humans by prophylaxing them after exposure with what he made was an extract of the spinal cord from an animal that was infected with rabies. So in this case it was a rabbit. The rabbit had rabies. He hypothesized that if he could make an extract of that spinal cord and inject it into a human, he might induce some protective immunity that would protect the human from coming down with rabies. And indeed it worked. So over the next few years, the advance was made to go about inactivating the rabies virus. So one of the unfortunate complications here would be if you're injecting rabies material into a human, you might actually transmit rabies. So the advance was to actually use a drug, in this case phenol, to inactivate the virus, but still produce immunity in a host exposed to rabies. So this phenol inactivated brain tissue is now referred to as the Semple rabies vaccine. And the way this is given is a human who's been potentially exposed to a rabid animal gets a series of injections of this material, and it induces a protective immunity. And indeed it was, I think, Rivers and Schenker who hypothesized that the neurological complications that came about from this was not because the humans were being exposed to rabies, but because they were being repeatedly injected with brain material. So this is actually how EAE came about. Unfortunately, however, in human patients injected with this material, there was approximately a 1 in 400 risk that patients would develop what were colloquially referred to as neuroparalytic accidents, meaning the injection of this vaccine led to the induction of a neurologic disease, which turns out pathologically to have inflammatory demyelination in the brain. Again, very similar to EAE, and so this led to the idea that the exposure to material in this spinal cord extract was actually inducing these neuroparalytic accidents in humans. So that's been the subject of a lot of study, particularly in the third world, where the Semple rabies vaccine was used for many years. It was inexpensive to make. It was very effective at preventing rabies, and therefore it was very popular throughout the world. So in Southeast Asia in particular, where there's a lot of rabies, investigators in Thailand were able to identify a series of 156 cases in Bangkok over an interval that led to this 1 in 400 number. And so they decided to study this in a prospective manner. So they were able to identify 61 cases of what they now refer to as SAE. So this is Semple rabies vaccine-induced autoimmune encephalomyelitis. Sorry, it's a mouthful. And they wanted to characterize these patients clinically, but just as importantly, they wanted to characterize what they thought were the immunological mechanisms at work here. It had since been recognized that one of the major proteins in homogenative brain tissue that could induce disease following injection into animals was a protein called myelin basic protein, or MBP. And so the hypothesis here was that the exposure to this material was generating an immune response to material in myelin, and therefore it was that immune response that was producing this disease. So in these 61 cases, which I'm going to tell you a little bit about, they subdivided them into two categories: patients who had major complications, including myelitis, and patients who had minor complications. And to just show you a little bit about the kinetics here in their 61 cases, most of the patients typically got sick after a week or two following this series of injections. So the hypothesis here, it took some time for the patients to mount an immune response to the material in the vaccine, and that material was that immune response was then leading to the development of symptoms. Fortunately, in their patients, many of them recovered. Indeed, almost completely. Patients had both central nervous system complications and peripheral nervous system complications, which I'm not going to talk about. And in general, this was a monophasic illness. Patients were sick for an interval of time, but then typically went on to recover. So the question was, could we start to study the immune responses in patients who developed these neurological complications following this vaccine and compare them to the immune responses in patients who had received the vaccine but who had not developed these neurological complications, compare and contrast those immune responses, and learn things about the pathogenesis or the immunopathogenesis of this disorder. So in these experiments, this group took lymphocytes, blood cells out of the blood, and put them into culture and stimulated these lymphocytes with this myelin basic protein that they hypothesized was something that the cells were responding to produce this disease. So if you compare the proliferation of lymphocytes, this is now being done in a dish of cells taken from patients who had received the vaccine but who had not had any complications, and compare them to cells from patients who had had complications following the vaccine, and study the proliferation of these cells in a dish in response to myelin basic protein, you can see that down here, patients who had major complications to the vaccine had proliferative responses to myelin basic protein to a much larger degree than in patients who did not have neurological complications. Again, implying that they were mounting an immune response to myelin basic protein, and possibly this immune response was causally related to the development of the neurological complications. So not only did these patients develop cell-mediated responses to these to this myelin basic protein, but they also developed antibody responses. So they looked both in the serum and the cerebrospinal fluid for antibodies against myelin basic protein, and they were able to identify them in patients who had complications here compared to patients who did not have complications. Again, implying that the development of immune responses to myelin basic protein predisposed these patients to developing the neurological complications, and in contrast, patients who did not develop these immune responses were spared these neurological complications. If you take the trouble to study this antibody response against myelin basic protein is a large protein, and if you break it down into little pieces, you find that there are several dominant epitopes in myelin basic protein against which many of these antibodies react to, and so you could characterize the specificity of these antibodies in greater detail. And furthermore, if you look at the isotype of these antibodies, and this is a little complicated in terms of immunology here, the patients who had neurological complications in the first bar compared to the second bar tended to have higher anti-myelin basic protein antibodies that were of the IgG1 and IgG3 subtypes, and that implies that they were driven by type 1 immune responses. So again, they have higher antibodies against myelin basic protein, and they were of a specific isotype. Furthermore, as further evidence that this was a T-cell driven phenomenon, they looked for HLA linkages in patients who developed the neurological complications compared to patients who received the vaccine and did not develop complications. And this is a little bit complicated, but suffice it to say that if you had a HLA allele, HLA-DR9 or HLA-DR17, those two alleles were overrepresented in groups who developed the neurological complications, again suggesting this was a CD4 positive T-cell driven response and genetically susceptible hosts. Okay, well, so that's a little bit artificial. You're injecting neural tissue into humans. You could envision that would be not a very good idea, and so there's been a move to get away from this rabies vaccine, and indeed cell culture-based rabies vaccines are now used. But I think this teaches us some immunological lessons here. So if there's some trigger that in a human that causes the human to mount an immune response to myelin basic protein, that has the potential to cause an inflammatory demyelinating neurological condition. So I want to change gears a little bit and talk about measles. So measles is not a big deal here in North America and the developed world because of a very effective measles vaccine, but it is a big problem worldwide, and it kills over a million children a year. In patients who develop measles, there is a complication of this infection that occurs in about 1 in 1,000 patients called measles encephalomyelitis. And this is a neurological disease characterized by progressive neurological symptoms, and in those cases that have been autopsied or biopsied, the pathology is inflammatory and demyelinating in nature. Furthermore, there's no evidence that this disease is caused by measles actually spreading to directly infect the brain. There's no evidence of measles virus in the nervous system. So the hypothesis was raised that this encephalomyelitis caused by this infection somehow triggered a cross-reactive immune response against neural antigens. And I'd like to show you a little bit of data to substantiate that. So this is sort of the characteristic of this post-measles encephalomyelitis. Patients who get measles typically develop a rash following an incubation period after infection. And the illness developed with kinetics not unlike I showed you following the rabies vaccine cases after a week or two of infection. So if you take the trouble to obtain blood specimens from patients who have this measles encephalomyelitis and do the same experiment that the investigators from Thailand did and looked at the reactivity of the lymphocytes from these patients to myelin basic protein, again, you can see that in patients who had the measles encephalomyelitis, there was a much higher frequency of reactivity to myelin basic protein compared to patients who had measles who didn't have the neurologic disease, or patients with, these were particularly children, normal children, or patients with other neurological diseases. Again, implying that the infection somehow triggered a cross-reactive immune response against myelin basic protein, and it's that myelin immune response that's driving the development of this encephalomyelitis. So in terms of the pathogenesis here, this is a bit speculative at this point, although there's some suggestive information and data to support it, that you get this infection and T cells that are generated against the virus to fight off the infection somehow cross-react to myelin proteins. Or pre-existing myelin specific T cells somehow get activated by the infection. In either case, these activated myelin-specific T cells work their way inside to the brain and cause an immune-mediated destruction of myelin and possibly actually the axons themselves in the brain, producing the neurological symptoms. And this has been the term to describe this has been referred to as molecular mimicry. Now, this doesn't project very well, and I apologize for that. So this is actually about 25 or 30-year-old data from patients with ADEM, again, looking at the proliferation to human myelin basic protein. So in the acute phase of ADEM, there's substantial proliferation to MBP. In patients who have recovered and stable, that reactivity goes away, and there's limited reactivity to myelin basic protein in normals or patients with other neurological diseases. Again, implying that activated immune reactivity to myelin basic protein is causally linked to the development of ADEM. So to just sort of compare and contrast these sorts of disorders, we talked about post-infectious encephalomyelitis, post-rabies vaccine encephalomyelitis, and this disease called experimental autoimmune encephalomyelitis, which, as I said, Dr. Ransohoff is going to discuss. These are all induced by either inoculation with myelin or central nervous system tissue or infection with a virus. They're acute onset. They're typically monophasic. They're occasional relapsing forms. Pathologically, they all are characterized by inflammation in the brain and demyelination. And immunologically, which again is the point that I've been trying to hammer home here, that these are characterized by both cell and antibody responses against myelin proteins, in particular myelin basic proteins. And the idea is that that's causally associated with the disease. Now, I don't mean to suggest that they're all the same. I told you that SAE is linked to HLA-DR9 and DR17. ADEM in one study has been linked to HLA-DR4 and DR5. Multiple sclerosis in a Caucasian population has been linked to HLA-DR2. So I think there are subtle immunological differences here, which may help to account for some of the clinical and pathological differences between these disorders. But nevertheless, all of these data suggest it's driven by a T-cell response to myelin. So, to wrap this up, ADEM is a demyelinating inflammatory disease of the nervous system. It's usually monophasic. It can occur shortly after a vaccination or an infection, and many patients who develop this condition show enhanced immune responses against myelin antigens. And again, the point I'm trying to propose is that it's the development of these immune responses which cause the development of the neurological symptoms. So, my question then is, are there immunological lessons here from ADEM which we might apply to transverse myelitis? So, just by analogy to what I've told you, is transverse myelitis associated with elevated or augmented cellular or humoral, this is antibody-mediated responses to myelin, whether it's myelin basic protein or any other protein in myelin? Why is it spinal cord specific? So are there certain targets of the immune system that are only present in the spinal cord and not in the brain that account for the spinal cord localization of this disease? Can we detect these immune responses, and can they be correlated with the clinical course of the disease? And of course, if you believe that it's causally linked to the development of symptoms, it would be nice to see if you could interrupt that and alter the course of the disease. So can the identification of such immune responses be translated into a more rational therapy for transverse myelitis? I think these are pretty broad and perhaps speculative questions on my part, but again, it was my intention to throw these data out and force a little bit thought about the immunopathogenesis of these diseases. And I think that's the end. Thank you very much. So I have 2.5 minutes here, and we have patients have MRI abnormalities that involve the white matter in the brain, also in the spinal cord, and many times they're difficult to distinguish from the lesions of TM or multiple sclerosis. Right. Well, so then if you buy my argument, so she was asking about the absence of lesions and the preceding flu vaccine before the development of her neurologic symptoms. If you buy my hypothesis that in some genetically susceptible individuals, the vaccine might somehow trigger an immune response to myelin. It's not meant to do that, but it unintentionally does that in a small percent of patients, and then that immune response to myelin is what causes the neurological disease. Now, I don't have any proof whatsoever of that, but it seems like an interesting and feasible question and experiment to try and do.
Another really strange thing is I got that flu shot and got whatever I have not had a cold.
Oh, it worked. So she hasn't had a cold since her flu shot in 6 years. So again, I want to reinforce the point that, you know, vaccines are important for public health. They really work to do the things that they're supposed to do. Unfortunately, in a small percentage of patients, there are adverse events associated with them. Dr. Kaplan. So he asked whether there are immunological differences between the myelin in the spinal cord and the myelin in the brain that might account for the site specificity of some of these disorders, or conversely, are these lymphocytes floating around in our bloodstream more easily accessible to the spinal cord than the brain? And the answer to both of those questions is I don't know and I don't know. It's very, I mean, I would think that that some of this site specificity could very easily be explained by antigenic differences here between myelin and the spinal cord. So it's a very attractive hypothesis. I don't know if anybody else cares to comment about this, but not that I'm aware of. I don't think we know enough about the myelin in the spinal cord versus the brain. Claudia. Is in the spinal cord. So you're going to hear about that from Dr. Ransohoff tomorrow. So the question was, ADEM is particularly common in the pediatric population. So one explanation for that might be that kids are more likely to get infections that trigger these things than adults. Or conversely, are there immunological differences in children versus adults with regards to their reactivity to myelin? And the answer to that is I don't know either. But again, it's a very, very good question. All of us actually have a few cells in our body that react to myelin. And yet that is regardless of whether you have a neurologic disease or not. So there's got to be something else that somehow triggers those cells, if you believe they cause the disease, to become activated and cause a neurologic disease in some people but not others. So there's got to be checks and balances here that keep them in check most of the time but not in other situations.
One more question and then a break, then an announcement and then a break.
It seems like a terrific. So the question was, if you just took a homogenate of spinal cord, forget trying to figure out what it's responding to, and a homogenate of brain, do the T cells respond to the spinal cord homogenate differently than the brain homogenate? That is an experiment that I would very much like to do, but I don't know the answer to that. I think it's an excellent idea. Predominant spinal cord involvement. Oh, so the question was whether I had neglected the M part of the ADEM and tried to make this more a brain disease rather than a spinal cord disease. And I think it's very heterogeneous. Sometimes there are patients who have this condition where it's predominantly involving the spinal cord and sometimes more predominantly involving the brain. So it's very heterogeneous in that regard. Okay, so we need to take a break.